My name is Naval Daver. I am an associate professor in the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. Today, I'll be giving a brief update on the data with the CD47 antibody magrolimab in combination with hypomethylating agent azacitidine in patients with acute myeloid leukemia and myelodysplastic syndrome. So the question posed to me was whether the combination of azacitidine with magrolimab is showing improvement as compared to what we would expect with azacitidine alone in patients with MDS and AML. There is data that was presented at the ASCO 2020 meeting, and also there will be two presentations at the EHA 2020, both oral presentations, one given by my colleague Dr. Salman covering the MDS data, and then one given by me covering the acute myeloid leukemia data. What we're seeing is that the combination of azacitidine with magrolimab now in about 65 patients aggregate data that will be presented at the EHA meeting is very, very safe. We don't see any immune-mediated toxicities, which is quite unique given that this is an immunotherapy that activates macrophages. We also are not seeing any unexpected or severe cytopenias, especially neutropenia, thrombocytopenia, or any unexpected infections. The one side effect that we do see is an early on-target anemia, and this is because CD47 is expressed heavily on the older red cells, and during the first 10 to 14 days when we're doing a ramp-up intrapatient escalation of the CD47, we do see an transient anemia, and usually by day 12 to 14 that stabilizes. In general, the safety profile is quite consistent with what we have been used to with azacitidine and decitabine alone, and the 60-day mortality on both AML MDS studies was 0. As for efficacy, in the MDS population, we have treated about 40 to 45 patients at the time of the data cutoff for this meeting. And important to note that most of these patients are IPSS high or very high risk. That is, our IPSS high, very high risk, makes about 70% of patients, and about 40 to 50% have adverse cytogenetics or high-risk features. So it's in general quite a high-risk population. The overall response rate that was presented at the ASCO and EHA is about 90%. This includes a true CR rate of about 45%. And what's interesting is as patients stay on treatment longer, 6 months or more, we're seeing that the CR rate, meaning all count recovery and bone marrow blasts below 5%, is improving over time. The survival also is very encouraging with this combination, and this will be shown at the EHA meeting with a greater than 85% survival with the current follow-up, which is short, but we hope that this will continue with time. Now, for the acute myeloid leukemia section, we're going to be presenting data on 29 patients, which is what we had at the time of the data cutoff. More patients have been enrolled since then. But among these 29 patients, it's important to note that these were all older patients considered not eligible for traditional induction chemotherapy, either because of age, performance status, comorbidities, other features. So the median age is about 74 years, and patients range from 62 to 86 years of age. Also importantly, we had about 72% or 3/4 of patients having adverse cytogenetics per ELN criteria. And this included 45% of total patients with TP53. Now, this was partly intentional because we started seeing higher responses and durable responses in TP53 mutated older AML, which is an area of great unmet need. And that actually led to the protocol being amended about 8-9 months ago to focus only on TP53, which is why we see such a high proportion of adverse cytogenetic TP53 population. The overall response rate reported is 65%, which includes a CR/CRI rate of about 55%, including a true CR rate of about 40 to 42%. And these are all much higher than what we would get with azacitidine alone, where the published true CR rate is about 18 to 20% across 2 large phase 3 studies that have been published in the last 5 to 6 years. More importantly than the remission being high, which of course is exciting, is that the early mortality was 0, showing good safety. And the duration of the remission so far seems to be quite encouraging. And with the median follow-up of about 8 months, we do not have a median duration of response reached. Most importantly, among the TP53 mutated AML, the numbers are quite small at this presentation. We only have 12 patients, but the CR/CR rate was 75%, which is really quite encouraging. Historically, with HMA alone, we see about 30-35%, And even with HMA combination with venetoclax, the response rate is about 50% CR/CRI in TP53. So this looks better. And importantly, the duration seems to be quite maintained with a median follow-up of about 8.5 months. We still do not have a median duration of response yet met, and the survival is also looking quite encouraging. So we think that especially among TP53 in the older AML, this could really be a major therapy. We are focusing on that population, enrolling more patients. We also looked at baseline variant allele frequency. Most of these patients had 30 to 80%, so high TP53 allele burden, meaning that these were true populations, not just a small subset of TP53. And we see in about 50 to 60% there is clearance of the TP53 either by MRD assessments, by flow, or by variant allele frequency measurement. So there is actually plans to look at registration approaches, both in frontline, high, very high, intermediate IPSS-R. There's actually a randomized phase 3 study about to start, or started in a few centers. And then separately in AML, there are registrational plans to look at the TP53 AML, where we think this data looks quite encouraging and better than the current standards of HMA or HMA venetoclax. Thank you.